Hi, this is Dr. Torino. I'm here with this episode of EVMS Ultrasoundbytes, and today we're going to talk about a focused evaluation of the kidneys. Today's learning session is going to focus on introduction to the POCUS application of kidneys, how we're going to set up our machine and some of the controls we're going to utilize, our patient setup and positioning, and the acoustic windows we're going to use. We're going to go through the steps in acquiring our images, talk about some pearls and pitfalls in scanning kidneys, and then I will introduce the scanning cards for this protocol that you will have access to. The clinical application behind POCUS is going to be for general assessment of the kidneys, and this can be to rule out a mass, which you would expect to see in the renal cortex, to rule out hydronephrosis, and additionally you would be able to rule out the presence of fluid in Morrison's pouch, which you would see just superior to the kidney. And here in this kidney, we see some hydronephrosis, and we can tell it's hydronephrosis because the ureter, the proximal ureter, is connecting to multiple renal calyces, both major and minor in this case. When we set up our machine, you're going to be sure you enter your patient information as instructed. We're going to use our equipment preset as either renal or abdomen. Either would be acceptable. We're going to use a curvilinear probe, although the phased array is perfectly okay. And we're going to keep everything else default until we begin scanning, and then we can make all of those adjustments. And on your machine, when you come over here, your patient information is going to be located on your main panel, and then often we're going to have you enter as your patient ID, your medical ID number. Okay. Okay. Do I have to start over, or am I going to just from where? Okay.
And then we go to the machine.
Okay.
Some of those, and use your PowerPoint to guide
Okay.
you.
Okay. I hadn't been going there yet. That was why I didn't.
Yeah, I'm just trying to get them to see the buttons more, right?
Okay.
Your slide
All right.
tells them what they're going to do, but it doesn't show them what they're going to do.
It doesn't. And I was going to do it when it said, let's go to the machine and do this. But I'll
But
just
it's
do it.
too many slides away.
Okay.
Right?
All right, good. Well, let's go to the machine and look at some of those controls. So on your main keyboard, to the left, you'll see the patient button. And if you hit that, you're going to let the machine self-generate a patient ID, but your last name is going to be your ID number, including a letter, and then in the first name for the patient, it's going to be your last name. And often you may be instructed, instead of putting your own name, since you have your ID, you may be instructed to put your course instead. So it might be MD, let's go this way, MD 105, just as an example. So you're going to have a couple of different choices, and then we're not going to do anything else here. We're going to come down and we're going to set over OK and accept that information, and then you can see that your ID and either your last name or your course number will be saved here on your machine. We're going to leave all our other controls neutral, except we're going to hit the button on the left side of your keyboard that says exam. And when you hit exam, you can see all of the selections that are available for this probe. So I have selected a curved array, And I'm going to leave it on abdomen, although urology or kidney settings, either of these, you have 3 to choose from, would be acceptable. The other thing you're going to see me do on this menu is once I get an image and I measure, which is over my horseshoe around my trackball, I'm going to come into my measure menu and I'm going to make sure that I am on right or left. I'm going to go to right first, and I'm going to be in the kidney first, and then I'm going to enter my renal measurements into this worksheet so that we have it as a review. This you would do clinically so that you have all your patient data together. Now if I return to notes, let me remind you that we're going to use our standard conventions with the marker to the patient's head for longitudinal, or the marker to the patient's right side for transverse. Your transducer movements are going to be the same as they've been. A heel toe, sweep or fan, and pivot or rotate. And patient positions, they're going to vary kidney to kidney. On the right side, supine might be quite fine. LPO is often the best. And for the left kidney, supine might be fine as well, but it'll make you work a little harder. And I'm going to put my patient RLD every time, and I'll show you that when we scan. Your labeling, again, you're going to be told what you're going to label, and so in this case it would have been renal and coarse. And remember, why is that okay? Because in the black area, in these triangles where there's no data, you're going to include your last name, at least your first initial, depending on the common nature of your name, your student ID, including the letter, and then some anatomic labeling, and that has to include a scan plane and a note about the anatomy. So we're going to image and document a long right kidney and a short left kidney at the mid-pole, and you're just going to include that data. That is very important for your patient care. You need some proof of documentation. And then additionally, you might have to label other anatomic information as instructed on your worksheet. When we talk about image acquisition, the things, of course, that you're going to adjust, the things that you've always adjusted, your depth. And you want to have 1 to 2 fingers between the bottom, in this case of the kidney, and the bottom of the screen. And you're going to adjust your focal zone. On this image, I noticed that the focal zone's in the middle of the kidney. That is incorrect. This focal zone should be at the deepest depth that the kidney reaches, and so it should be located more deeply. You're going to adjust your gains and your TGC to overcome some attenuation without making anything too bright or without giving anything bands on the image. And you're going to make sure that you pay attention to your notch so that your transducer has proper orientation. And then lastly, you're going to pay attention to your anatomy. Now this is big and you're on one side of the body or the other, it'll be easier, but always remember to pay attention. Acoustic windows for the kidneys, as I mentioned, in terms of patient position already. But when you're scanning, what are you going to do? Well, we've always said try deep held inspirations, so you're definitely going to do that. And if that doesn't work, something else you can try is a pooch their tummy. I don't know that it will work every time, but when it works, it'll be very helpful. You're also going to be very careful to make sure that you slide through the kidneys all the way. You have to see beyond the edges of the kidneys because many renal cysts and masses are exophytic, and you'll miss them if you don't do that. Again, we talked about your right kidney, really typically going to be held inspiration, and you have several scanning windows. You can scan mid-costal, mid-coronal, or intercostally. Now, I would say that intercostal scanning should be your last choice, but I'm going to also say that you're often going to need it. Left kidney, you're going to have a much easier time if you put your patient up on their right side, left side up, RLD. Use a held inspiration. That might it might work. You might not have to have a big held inspiration. And you're going to scan mid-coronal. Start at the natural waist, move north superiorly, and rotate the probe slightly clockwise to elongate the kidney. Once you have elongated the left kidney, you are going to, in standard format, rotate your probe counterclockwise 90 degrees to achieve short axis. It's not going to be a true transverse. And again, in short axis, you also must move through the kidney beyond upper pole and beyond lower pole to make sure you find any exophytic masses. We're going to scan now, and we're going to decide the best windows for our kidneys. We're going to optimize our settings. We're going to survey the right kidney, left kidney, and we're going to take our measurements. And finally, we're going to begin to experiment with color and power Doppler today. So, I have warm gel. Gums, probably not as warm as anyone would like. So I'm going to make sure that my notch is facing my patient's head. And I'm going to say, take breath in, please. And I'm going to start mid-costal marking. I find that I see a lot more of the kidney. And here I am, mid-costal. Patient has held inspiration, and that kidney is beautiful. So I know that's going to be an acceptable window. I'm going to survey my his right kidney first. Take that in. Hold it. And by doing that, what I'm going to do is I'm going to move medial until kidney's gone. There's some gallbladder right here. And then I'm going to move lateral until kidney's gone and see any masses. Breathe. I'm going to rotate counterclockwise to transverse. Big breath in. I'm going to come superiorly. There's portal vein, gallbladder, finally upper pole, mid pole, lower pole, and gone. So for today's lab, your image requirement is a long kidney. Big breath in. And you're going to measure two things on that kidney. Now, breathe. As I was scanning, I was paying attention to the bottom of the screen. I have about almost 2 fingers between the bottom, so I like that. My focal zone's pretty much at the bottom of my kidney. So I'm going to hit measure. I'm on the right side, and I'm on renal length. Set. And then I'm going to come and I'm going to put my caliper at the tippy tip of a kidney. Set. And I'm going to come to the other pole straight across the middle of the kidney and set again. The second item you have to measure in this image is the thickness of the cortex. So I'm going to select that. I'm going to, by hitting set, and I'm going to put my caliper at the base of a pyramid. So these pyramids are these lovely little chocolate chip cookies that a nicely hydrated kidney will show. I'm going to put my caliper at the base of the kidney, hit set, and I'm going to move my caliper straight out to the cortex. We would actually like the cortical thickness to be at least 1 centimeter. In small, very slight patients, you may not get that much thickness, but that would be our goal. Here you see this measurement is 1.2. This is a wonderful indirect indicator of renal health. The next thing that we're going to do while we're here on the right side is big breath in. I'm going to come back to this long kidney and I'm going to select the button that says color. And I'm going to look at flow in the kidney. Now you will have to make the same adjustments that you have to make with imaging. Breathe. You're going to have to change your, potentially your focal zone and your gain. I want you to note on this screen that our machine moved our focal zone for the color box, but left our grayscale focal zone just where we wanted it. You can tell you have color Doppler in use because you have a red and a blue map. You have a 2-color map. Breathe, please. I'm going to now contrast that, starting with color Doppler with a 2-color map, and I'm going to now select the button that says power. Now we have Doppler, but we have 1 color scheme. It's all a solid color scheme, and that's how you can tell them apart. Now these are quite different tools, and they have different strengths. Breathe. The strength with power Doppler is that it is much more sensitive, and if there's any doubt, this is an excellent tool to be able to double check that flow goes all the way out to the very base of the renal capsule, all the way out to the edge of the cortex. What does power Doppler not do? It has no directional information, and it has no velocity information. Why? It doesn't rely on an angle, so it's easier and again more sensitive. Now I'm going to move to the left kidney, and to save myself the reach, I'm going to ask my patient to roll up towards me. Oh, wait. Thank you. Sorry. Okay, roll up towards me. Thank you. And I am going to put some gel right on this natural waist. If you try this position, which I strongly encourage, I encourage that you have your patient take their left arm and stretch it out, make their waist nice and long. So I'm gonna put my probe right on the waist at mid-coronal plane, and I'm gonna say, big breath in please. And I'm gonna rotate just a little bit clockwise and look at how much that kidney elongates. How do I know when a kidney is long? Well, if the poles are round, it's not long enough. And when you get the kidney nice and long, breathe, then you start to see that the poles get just a little bit of a pointy to them. And that can be a good tool to help you. Big breath in. So I'm going to reduce my depth a little bit, drop my focal zone 1, stretch this kidney out so that I can move through it medially and through it laterally to make sure there's nothing there. Breathe. I'm going to rotate my probe now 90 degrees counterclockwise. Big breath in please. And I'm going to move through my kidney. Lower pole, mid, upper pole. Can't be any more upper pole than we're in the spleen now. Upper, mid, lower, out. Breathe, please. So the image that we're going to get as required here in the left kidney is big breath in, please. is going to be mid-pole. Breathe. And so you may say to yourself, how can I be sure I'm at the mid-pole? Well, the answer is you'll see the hilum. So look for the hilum. It will really help you, especially as we go to measure. So as I go to measure the left kidney, I'm going to select left. And now we're measuring in transverse. So I'm going to select width first. My width caliper is going to be set right at my renal hilum. Set. And I'm going to go all the way to the outside of the renal capsule. Set. Then I'm going to come to renal height. And I'm going to go perpendicular to that. Actually, I want to redo that. Let's get that width a little straighter. I was sitting at an angle. All right. Now we're going to go to height. And we want this to be perpendicular and form a 90-degree angle with our first caliper. Done. And there would be your required image for the left kidney. Before we leave the left kidney, I want to return to an elongated plane, a long plane at mid-coronal, and big breath in. And I want to put on color Doppler. I can hit set and adjust the size of my box. You can see the two color map. Now look at the cortex, and you can see that flow doesn't go quite out to the edge. Look what happens when I put on power. You start to see it getting closer to the edge of the cortex because of that increased sensitivity. Breathe, please. One more thing before we leave is just to make sure, quick look, we look around, we didn't miss anything, we've confirmed our poles, we've looked at the kidney with color, and so that is it for our scanning exercise. Do remember that this might be part of a larger protocol, and you might have a requirement for looking at the bladder. I'd like to return to our notes now for just a few minutes. And as we do so, I want to talk about the scanning pearls and pitfalls for the kidneys. So the first one I talked about while I was scanning. How do you know when you've done a good job stretching your kidneys out? Make the poles pointy. It is a little harder to do on the left kidney. It's not as obvious, but there's still some point to it. You don't want those poles to be blunted and round. And how do you know you're at the mid-pole? Well, you've got to see the hilum. I said that when I was scanning. But here's something to think about. You've got to pay attention to your anatomy. I can tell what kidney you're looking at by where the hilum points. Both hilums are going to point medially. But for a right kidney, you're going to be looking anterior, posterior, and right and left. And so that hilum is going to be coming kind of straight out to the right side of your screen. On the left kidney, you're going to be coronal, and it would be lateral to medial and anterior to posterior. So that means for left kidney, the hilum comes out more towards the bottom of the screen. So we can actually tell an awful lot about whether you're right or wrong in your anatomy by looking at these landmarks, and so can you. What else? Let's talk about anatomic variants. In anatomic variants, we see a lot of defects as renal capsules develop. Some of those defects are just little pinches, and we call them a junctional defect. These are just small divots in the renal capsule, and they do not extend all the way through to the renal sinus. Sometimes they do extend to the renal sinus. Those patients often have multiple capsular defects. They are often deeper, extending all the way into the renal sinus, and we call these fetal lobulations. And the next clinical pearl I'd like to leave, you can tell how important kidneys are. They got 2 pearl slides. I want to remind you that kidneys have a lot of variations in them, and one that's pretty common is a duplex collecting system where you have 2 separate collecting systems leading to 2 ureters, which may or may not fuse as they move distally. Now in transverse, you're not really going to be able to tell that there's 2 unless you move through them. But when you're transverse, you are going to be able to see 2 separate collecting systems in the kidney that are separated by some parenchyma, cortical parenchyma that goes all the way through the kidney, and you're going to notice that these kidneys are often a little bit longer than single collecting system kidneys. Maybe not longer than, upper limits, but a little bit longer. Artifacts are pretty common. The pretty common artifacts here, you might expect to see some enhancement, some shadowing, and we see some we see some shadowing near the upper pole, and you might expect to see edge shadowing. We have edge shadowing here, a very good one at the lower pole, and so just common artifacts. Your SPI snapshot is going to come back to Doppler because this is the first lab that we focused a little bit on color and power Doppler. So both color and power Doppler are qualitative. This is important because you need to understand that neither of these tools give you a peak velocity for these vessels. The difference, color Doppler has 2 hues in its map. Power Doppler has 1. Color Doppler will alias. That means you might see complex, complicated colors instead of just these nicely defined reds and blues. Power Doppler will not alias. And color Doppler is very, very sensitive and limited by depth, frame rate, and angle. So you want to keep your scanning box very small. Something that can help is turning your grayscale gain down. Power Doppler is much more sensitive and does not suffer from those same limitations. Related to color Doppler and power Doppler, how can you apply them clinically? Rule out kidney stones. And the great thing is stones twinkle. If you think someone has a stone, you can put color Doppler on, turn your scale very low, and you should see some color from the natural from the natural vibration of the stone. Everything in the universe moves. It all oscillates, and this stone is doing the same, especially as this mechanical sound energy goes through the body. How does that become adjusted? It becomes adjusted with these 2 controls right here, because in order to make sure you make the best use of your color information, you need to set your scale appropriately, and you need to think about how fast blood would go in that system. In a carotid artery, blood can be going 100, 150 centimeters a second and still be considered normal. In the kidneys, by the time you get out near the renal capsule, blood is only going about 5 centimeters a second. So you need to use a low flow state and a low number in your scale to make those adjustments correct. And you have to remember that everything has a limitation, and it's this 77,000 law. And eventually you might come to a place where you can't fix your image. It's probably not you. The images for this lab, on the right kidney, an elongated right kidney, you're going to measure the longest axis from pole to pole, and then cortical thickness from the base of a pyramid out to the capsule. On the left kidney, you're going to be in the short axis, again, lateral to medial, anterior to posterior. First caliber goes on the hilum, second goes across, and then the second set perpendicular to that. I'd like to thank you for this session of Ultrasoundbytes from EVMS. This is Dr. Torino, and we're done for today. Thank you very much. Bye.